No medicine can remove the cause of a lifestyle disease, but you can. Welcome to this 5-part video series, before and after. We talked about various treatments, major treatments, and procedures for lifestyle diseases. In this series, we were dealing with the heart disease, and in the second part, we are looking at what are the latest options available for those with heart disease. We have with us Dr. Jolly Thomson, who has extensive experience of over 35 years in the field of medicine and lifestyle disease. And this we'll start with the question of, after an angiogram, sometimes it happens that, the patient has a block, and then what next is the question. So that is something like, maybe the patient may have an idea that there may be a block and something has to be done about it. But even then, after the doctor tells there's a block, now we have to do something immediately. Or if the doctor says we can wait for some more time, what is it that actually the patient feels?
Basically, the current method of treatment, we can take it different. It's medicine plus lifestyle correction. That is one method of treatment. And next is angioplasty plus lifestyle correction. Third is bypass surgery plus lifestyle correction. And the fourth is, actually this fourth is not commonly available. I don't know anywhere that is the way. Actually, I am expert in clinically supported lifestyle correction for heart problems. So I have treated many patients with all category. Those who are, doctor, I am having hypertension, and my father or family history of diabetes is there, or family history of heart attack is there. So they are as a preventive, they are coming. And another patient may be diabetes, hypertension, and cholesterol for many years. They may be taking treatment, and because when they gone for a general checkup, this yearly checkup, they found that there is some problem, or this TMG is positive, and they have advice for angiography. And there are other patients who have done already an angiograph, and there is they tried the prime. This usually along with the angiogram, they try to put the stent also if there is a block more than 70%. Generally, all the hospitals, and depends on the hospitals. Some I had seen those who are inserting stent for 40%, 50% block and all. But general concept is more than 70% block. If it is can be applied, they put the stent also. And there are patients who are not able to put the stent. Even today, I had a patient. Their angiogram was done, angioplasty tried but failed. So then there will be usually advised for a bypass surgery. And I had patients who were advised for a bypass surgery. They also came for this clinically supported lifestyle correction. And I had patients who had already done bypass surgery and many times angioplasty, and there's nothing more to do. And now they have a severe unstable angina, and the stable angina or unstable angina, their activities are so limited, and they're having even difficulty in pain even during the regular work, like taking bath and combing hair, all become difficult. So all different sort of patients I'm seeing and regularly treating. So in generally, this all these procedure, the base, whatever is the thing, you have to do the lifestyle correction. Even the latest studies, so many studies are also came out. It all shows that whether you're opting for the here in the our part of the country in Kerala, there are so many cardiologists itself is giving those who are wanting to avoid angioplasty or bypass surgery. The cardiologist itself is treating with the medication. I am getting that. I'm treating those patients under care of such cardiologist also. So in all these things, the base is actually lifestyle correction. We should understand that the heart attack or the cardiac failure, or it is not because of the lack of medication, lack of surgery, or basically it is lack of lifestyle. The problem is the erratic lifestyle, or we are not our lifestyle has changed, but we are not our food habits and other things are not adjusted to that. That is the reason for increase in the heart attack nowadays. So we had to find out, the patient should understand that what is wrong with their lifestyle and what is the reason, fundamental reason for it. And if you are taking medication for actually medication is for only this blood thinners, and statin for the cholesterol lowering agents, and the blood thinners, that is clopidogrel or the aspirin, and the other medications for the diabetes, hypertension, all these things. Actually, there's no clear medication for a heart disease. Only you are giving symptomatic or the test-wise. This cholesterol lowering, blood sugar lowering, BP lowering, those medications are only on that point of the view. It is there. There's no clear-cut medication to prevent, to remove the clot, or remove the clot. If in an acute attack, there is clot lysis medication also is there. And so what we have to understand, that the mainstay of the treatment is lifestyle correction. And if you can give it in a proper manner, that itself is sufficient. That is what my experience tells me, actually.
Actually, when you are talking about these treatments, generally the feeling is, if there is a block, the patient understanding or the well-wisher's understanding is that block has to be removed. And regarding the attitude, generally it is something like, if it's an immediate danger, then it has to be done immediately. Otherwise also it has to be done, but after a little time. But at the same time, it is heard that, if there is the situation is stable and the patient is stable, this is what we hear. If the patient is stable, there is no issue in waiting for some time and trying to correct it by utilizing lifestyle methods or medications or whatever else, and that doesn't increase the chance of any future heart attacks more than doing that immediate surgical intervention, or as earlier said. So how is this to be understood by patients? Because patients will always think, if this was not done, then they are at higher risk.
The patient should understand that the latest study shows that if you are taking medicine plus lifestyle correction, or a stent plus lifestyle correction, or the bypass plus lifestyle correction, the life expectancy is the same. Or to get a heart attack, the possibility of getting a heart attack is the same for all these three groups. So then, if you are taking medicine, anyway, you had to, after the angioplasty or the bypass surgery, you had to continue with the medication. And actually, after angioplasty, you had to take more medicine for the, especially blood thinners and other medications. For a higher quantity of medicine is needed for the next at least 1 year. And after the bypass surgery also, see, these blocks are actually only a part of the block is, it's actually plumbing work. That is, this putting a stent means it's a plumbing work. And some part, the stent is only 1.5 to 2 centimeters length. Only that the spot you can correct it. But your blood vessel is almost 60 miles. Blood vessel is there. It's not the coronary artery alone is affected. The whole body blood vessel is affected. That is why many of the coronary artery heart patients who had a stent and or the bypass surgery, they may be having this peripheral vascular disease, and many of them will be diabetic, and they may not be distinguishing. I am between when this neuropathy and all comes, they think that it is because of the diabetes alone or because of the sugar. No, because it is not because of the sugar. Blood vessels are getting damaged. If you have pain when you're walking, you have pain or numbness or burning sensation, you're finding it difficult to sleep. If you are doing a Doppler study of the leg, there will be atherosclerosis of the leg. Small vessels will be there. And nowadays, not only the stent is applied on the coronary artery, it is applied on the leg also. But the problem is, the stent can be applied, it is only for 1 or 2 centimeters, and it is only if it is the blood vessel is big enough. If there is a major block, you are putting a stent, but after that, that part of the stent, after that part of this, the small blood vessels also blocked, there is no use. And also, the most important risk is there is a possibility of restenosis and even to get a clot on the pot of this stent. If you are not taking the blood thinners in the correct manner, and immediately after within 1 or 2 weeks, and if you miss 2 or 3 days, this blood thinness, you can get a heart attack, repeat heart attack, and a massive heart attack because of the blocking of this major, because the this stent is put in a major blood vessel only. So if the attack is coming or the problem is coming on a minor blood vessel, you won't go into a death or major problem. But if you are the major blood vessel where the put a stent, and if you miss this blood thinness, and getting a clot means it can be even fatal. So that we have to understand. Everyone should understand that if you do a bypass surgery, that doesn't mean your life expectancy is increased. If you are putting 1 or 2 stents or 3 or 4 stents, it is not increasing your life expectancy. That is the result of this long stent study I am telling. So what is actually extending your life is the lifestyle correction. So whatever is done, even you take the medicine, if you are taking doing the lifestyle correction correctly, your life expectancy and the quality of life will be improved. And in my experience, I'm actually, those patients will be having a diabetes, hypertension, all these predisposing factors, the causative factors has to be removed first. I'm not for even diabetic patient. Diabetes is the most common reason. Diabetes and diabetic patient will be definitely after a few years, hypertension will be there, because the hyperinsulinemia is the reason for the type 2 diabetes. And the hyperinsulinemia will invariably, for a long run, this hypertension will come, because the insulin is a produce sodium retention, and it will give to, and also fat deposit, weight gain. This diabetic medications, all insulin and all the diabetic medications will promote the fat gain, and it will increase the insulin resistance and increase. That's the reason why if you start with the medication for the diabetes, it will be going on increasing. What I understood from the claim, my experience and my so much of from the experience from the patient result. So it is very easy to correct the insulin resistance and blood sugar without the medication. I'm seeing these patients who are advised with many 20 years, 25 years, type 2 diabetes, hypertension, dyslipidemia, all these medication, and advised for bypass surgery, or had a stent many times. All these patients, I'm able to reduce taper of the medicines within a month. And diabetic, if it is a type 2 diabetes medicine, when we start the clinically supported lifestyle correction itself, we stop the diabetic medicines, insulin injection. Why? If you are taking with a really correct low carbohydrate diet, if you take such medicines, you will get a hypoglycemia. Hypoglycemia is more dangerous than a hyperglycemia. So, and if the patient is following, because it is a very clear protocol is there. If the patient is following the protocol, the patient within 12 to 24 hours, blood sugar will be under control. So that is the pattern. And within a week itself, the BP started reducing. Only thing, when those patients who is taking clinically supported lifestyle correction, if they are on medication, especially the this cardiac medicines, that nitroglycerin. Nowadays, I am seeing so many patients with 2-3 this blood vessel dilators. That nitroglycerin group of medications are there. So such patients, if according to the BP is reducing, if you do not reduce the medications, they may get giddiness or dizziness, and the BP fall can. So in the initial stages, only thing we have to monitor the blood BP. It can be done at home itself, and reduce the medication, and clear direction will be given on reducing the medication as per the reduction in the blood sugar, BP. And the cholesterol can be initially we follow up with every weekly cholesterol and the lipid. It's not actually the cholesterol. We give more importance for the triglyceride and HDL. And usually the triglyceride, those statin, according this within a week itself, most of the patients, the triglyceride will come down, and that statin level will reduce gradually, and the BP medicine also gradually according to this thing. So it's a simple only thing. The patient should have an understanding about it.
We discussed on the aspect of angiogram and then putting stent and all that. And also regarding this bypass, the issue normally they say is, bypass is done when 1 stent or 2 stents is not practical, and it's having a systemic sort of failure. So, but in spite of doing bypass also, just like stents, we hear that sometimes these bypass patients are found to be again advised bypass once more. So stent also and bypass, this repeat requirement is happening. So what is wrong with the approach towards these patients, or what is wrong with the approach in general, that is creating a situation where the same patient is treated for the same problem again and again?
This modern medicine actually, these things are in the last few decades, these are come. And now it is very clear that previously we were thinking that the statin will give when the statin is first came to the medical field. So everyone thinking that all the problem with this heart attack is because of the cholesterol. And there is a cholesterol lowering agent that is very effective also. So everyone in the medical field were thinking that it is preventing the heart attack, and we are getting this miracle medicine for the heart attack. But it is very clear that there's no use of much use is there, because many patients on heavy cholesterol, anti-cholesterol lowering agents, and even this their cholesterol is very low, but heart attack is coming. And the stent, the multiple times stent is applying, and the once the stent is doing, then again stent, it is continuing. And one bypass, and there are many patients who, if it is possible, the doctors will advise more bypass. But the problem is the bypass risk. You have to bypass surgery. You have to have this blood vessel. So it has to be taken from your leg or the hands or your chest wall itself. So everything there will be a compromise, and you should understand it is not a small bypass surgery. Is not a small surgery. You have to cutting open this sternum, the chest bone itself, and to that this all the rib cage is attached to that, and it is cut and opened, and the pericardium is opened. Then you are in this. Luckily, the heart blood vessels are externally. It is running on the external. You might have seen the pictures of the heart. And so you are doing either this internal carotid arteries, that is the two arteries are supplying your this chest wall from the anterior, and that will be separated and taken. It is given to the heart part where it is blocked. The problem, if it is both is used, your compromise, it will the healing. If it is one is used, body will adjust to so many ways. That is why we are able to do all these operations. Actually, so if it is both the internal carotid artery, internal mammary artery is used, the healing will be get affected. So it is very good, because it is actually it is only one bypass. Is only it is taking it's from the aorta. It is from the aorta. It is stitched to the after the block. But if the small blood vessels also is blocked, what is the use? There's not much of use in that. So, and also the blood vessels from the leg is also taken. So it will actually giving scarring there, and many of the patients may be having, these patients may be having atherosclerosis of the leg and also the varicose veins. So there is compromise is so much. Even if you are doing all this great effort and you're having all this pain, but your chance of getting extended life expectancy or reducing the chance of second additional attack is nil. That is what the latest studies are showing. But many of the patient doesn't know that. That is why they think that the people are thinking non-medical, this layman is not reading any, this lot of studies and all, no one is looking into. Only the doctors is knowing. So you should pay the people also, because it's all, there are so many interests and so many controlling factors and all is there. So each patient should, before you undergo the bypass surgery or the stent, you should also try to find out what is the benefit, what is the risk, and such things you should find out the real risk. Even this unstable, you are talking about the unstable and stable angina and all. When the patient is unstable, and if you are doing a procedure, especially the angiogram and angioplasty, the risk is very high. 3 to 7% chances even death is there. That also we should understand. It's a interventional or elective angiogram and angioplasty is much more safe. When the patient is in pain and in the problem stage, there is also risk is there. So all these things patient also should understand.
Actually, when we are talking about these issues of intervention, generally the common concept is that if this surgery or this intervention is done, the problem is taken care of. At the same time, we now hear that the problem is not taken care of. It is basically the symptom that is really taken care of. And in another way, if it's a emergency like an attack and all that, of course we understand that that takes care of that immediate issue, immediate aspect. But why do you think patients fail to understand that this procedure is what is done in the hospital, and the correction in the cause of it has to be done at home? Why is it that you think patients fail to understand, other than the few patients who actually look at it in a more wider perspective?
What I see is usually after the bypass surgery, the people will be more sensitive about their lifestyle correction and all. Or after putting the stent also, they are not that much bothered about it. Because it's a minor procedure, didn't have much pain. But after the bypass surgery, usually people will have really more conscious. Actually, that lifestyle correction is actually giving benefit. It is not the bypass surgery or the stent, putting the stent is giving benefit for their health. So now also the current trend of the globally, the trend is to treat the diabetes, type 2 diabetes also with the medication and the insulin. So actually, many, because all these treatment protocols have started many years back, and we were not knowing the real cause for all these things. And when we were 100 years back, we got insulin, and we started. And then that time we do not that what is the difference between type 1 diabetes, type 2 diabetes. We were not, the medical people also was not aware of. Now we have very clear knowledge that why it is how the type 1 diabetes comes, and how the type 2 diabetes comes. But the management is given the same. Only thing that tablets is not effective for the type 1 diabetes. That is the only change we have really putting in. And the people, and even the many of the senior doctors doesn't really know that the difference between the type 1 diabetes and type 2 diabetes and the insulin, that what is the role of insulin in producing these blocks. That is because everyone is confined to their own specialty. So only those who are treating that part, they're looking into that. This actually, the endocrinologist only knowing about this insulin. The cardiologist is not looking into the what is the action of insulin, what is the insulin resistance. I have not seen any doctors is looking for this insulin level. Everyone has a routine like the cardiologist. I'm saying cardiology prescriptions and all from the Kerala and also the neighboring states, and even from the US and the other foreign countries also. But no one is looking into the insulin resistance, and no one is trying to reduce the insulin resistance. If the insulin may be 200 and the maximum it should be 25, and ideally it should be around 5. That is enough actually. If the sugar level is normal and if you are managing, that much insulin is enough. But it is almost 100 times higher in many of the patients. And they will be having all this fatty liver and finally into the cirrhosis. Actually, this insulin, the basic cause we are not addressing, because there's not a medicine for that. And doctors doesn't have any thing to give for stopping the insulin resistance. We have medicine for reducing of the cholesterol. We have medicine for reducing the insulin, reducing the glucose. But there's no medicine to reduce the insulin resistance and reduce the insulin level. That's the patient's responsibility. That if you control your calorie intake, and if you can do the exercise or physical activity, then it naturally come down. And the most easy to correct also with the lifestyle correction, the insulin resistance. Actually, we check the insulin level in the after 7 days itself. On the 8th day we check, and it is definitely 90% of the patient, 99% of the patient, it must be come down. But the cardiac patient, everyone, it will be very rare case of arthritis and all. Sometimes it will maybe, but as in general, within a week itself, the insulin level will come down. May not be the normal low level, around 5. Within a month, it will be, if the patient is managing correctly, it will come down to around 5, 6 and all.
Actually, we hear that almost 90% of the heart attacks have something to do with the damage to plaque. That is, either plaque is eroded or there is a plaque rupture and all that. But at the same time, we understand that none of these procedures in any way protect against that plaque rupture or plaque erosion, other than for a specific place or something like that. Sometimes it is done. So what is it that really the patient should know about this plaque rupture or plaque erosion, because when they are considering their heart health and the procedures that are done for that?
Basically, as I said earlier, this putting in the stent is a plumbing work. It's a bypass surgery, is a plumbing work only. Actually, the heart is having this, just our plumbing system is there, and also the electrical system is there. For the heart, the pumping has to correctly, there is nerves are there. There's a heart itself, there is a cardiac skeleton is there. Inside that, it is very protectedly placed this heart, nerves. See, irregular heartbeat, that is one of the major thing, and arrhythmia, that is ineffective heartbeat actually. That comes and going to the cardiac arrest with the massive heart attack is mainly because of this lack of blood supply to the major blood, nerves actually. That this pumping is, this muscle action is taking place only because of the nerves activity. If the nerves is not getting enough blood circulation, it will go off. So that is actually creating this sudden cardiac arrest and death. So within 10 minutes, if you're not able to bring to the hospital or revive the CPR or revive, the patient may go into coma. Even if you are able to restart the heart, the brain may be dead. That is why many of the people are taken to the hospital. All the possible things are done. This pipe, angiogram, angioplasty, everything is done, and patient may be in the ICU for 1 or 2 months and then pass off. So that is one aspect of it. So what we have to understand is, when you are having a heart problem, the most important time is not when you are getting a heart attack. So definitely, if you are getting a heart attack, you have to go to the hospital, stabilize the patient, and immediate this clot, if it is lysing of the clot is needed, it has to be done. But or if there is a clot is there, we can definitely put a stent and open up the blood vessel within 2 hours. That is the ideal time for opening up, so that the cut muscles can be served from a vascular damage. So those things we have to do. But remember that whatever you do, you had to do the lifestyle correction and come out of the predisposing factors. Not only the smoking, alcohol. You had to come out of diabetes, hypertension, and cholesterol. You should be able to control it without medication. So I'm telling it confidently because with my experience, as I said, if the patient is willing to follow the protocol, actually I call it a cell activation protocol, CSLC cap we call it actually. So with that, we can, with evidence, with the clinical monitoring, we can come down, and you can, I have seen patients with the HbA1c 13, 14, with the maybe taking medicine and so many hypertension medicine and 13, 14 tablets, different type of medications they are taking. And most of the cases we'll be able to, almost all the cases, I have no failure actually on the treatment or the protocol side. Only the patient may fail, and they may not be, because of so many family problems or so many hesitancy, they may not be able to. That is also very few only, because we are selecting the patient in such a way that they are really interested in this clinically supported lifestyle correction and come out of medication. Such patients, actually within a month, they'll be free from all the medicine. Only thing, if they have put a stent already. If there, I had patients who had put a stent last month and they want a repeat stenting or a repeat bypass surgery is needed. If the stent is put, then you have to take the blood thinners for a year. Otherwise, the repeat clot formation can be, that is because of the treatment induced, because the stent is a foreign body is there. It has to get covered with the blood vessel lining itself. Till that time, you have to take the blood thinners. Otherwise, and also one more group which is an exception, that is those patients who have put this pacemaker inside. Actually, we are thinking that the pacemaker is put on the chest. Actually, the leads, that wire is given to the heart, cardiac chambers. So in such patients also, they had to take the pacemaker is put lifelong, this blood thinners has to be taken, anti-clotting agents has to be taken. Otherwise, it will be risk for the patient. All the other patients will be able to come out of the medications. Only while they have a stress, they may have to take because of the stress level is increasing, hypertension, or when you're eating high carb diet once in a while for enjoyment also we can eat. In that time, specific medication also is given to not to increase the blood sugar. And our aim is actually bring down the HbA1c to 5.5 and blood pressure level to around 120/80, and many patients complain that the fourth medication already was taken for the BP, but now some are telling that my BP is going down, doctor, only 110/70 or 160 is there. So that is the normal BP. That is possible without medication. Even those patients who are taking many years antihypertensive, they can come down. They can come out of diabetic medicine. And also the cholesterol. Actually, we are not trying to bring down the cholesterol much. So in the Indian, especially in our part of the country, it is around 200 to 240 is a normal cholesterol only. But the triglyceride has to be kept below 150. That is, we are giving importance. And also HDL level. It is keeping HDL level and the triglyceride in the normal level. The cholesterol level, we are not looking into it. It's only with the statin you will be able to get the very low. Some cardiologists will keep it LDL below 100, and such things it is only artificially created. But we should understand that if you're taking such a high dose of cholesterol, the patient may be very tired and muscle pain, and the sexual dysfunction will be there. That is the major side effects of the cholesterol. And also, these people will start feeling dementia. The memory will be reduced because the cholesterol is very essential for the functioning of each cell of the body. The integrity of the cell is kept with the cholesterol. So if you are blocking the production of the cholesterol with the statin, it can have many consequences, and it may not, because so many millions of people are taking these heart patients are taking cholesterol, but they get repeat attacks. So it's a general. We can simply logically we can understand that it is not the cholesterol alone is creating problem.
There is a general understanding that just like plaque, rupture of it or erosion of it is primary cause of heart attack. Similarly, there is a general understanding that inflammation is the primary cause of plaque rupture or erosion of the plaque. So, what is it that a patient should understand? That what is it that the treatments give the patient with respect to managing this inflammation? Because when you look at it, it seems that inflammation is what is to be managed. Inflammation should be controlled. So how does angiography and angioplasty and bypass and other surgical procedures help in that?
We can take this plaques, these pimples. This younger teenage people, they get pimples on the face. Just like it is when it is ruptured, when it ruptures, when it is mature, it will rupture and it will come out the pus, this fat tissue. Actually, it is only lipids actually inside. That is the pimples is a formation of this sebaceous glands. That is oil producing glands. Just like pimples, it is inside the blood vessel, and when it is increased in size, it can come by rupture. It's just like the pimple is ruptured. When the pimple is ruptured, we have seen that there is blood is also coming out, and the blood there also blood will also come out because the blood there is an inflammation, and then what will happen? There will be clot is formed inside. So it is actually going to produce that clot is actually when it is blocking the blood vessel, you get an attack. That is the simple, just like this. I can consider it's just like pimples inside the blood vessel, and it can rupture, and it will give a massive attack or a mild attack or an unidentified attack. Depends on the size of the blood vessel. When we consider about the inflammation, how this bypass or stent is reducing, whether it is reducing inflammation? No, actually, it is increasing the inflammation. If you are putting a stent, the procedure itself is inflammatory, because when any foreign body is introduced into the body, the inflammation, the body's defense system will be activated. When you put the stent, the inflammation and clot formation will be very high. So that is why initially the uncoated medicated stent, initially the first generation stent was a failure. So the patient will get the clot on that and the attack can come. Then we discovered this coating it with the anti-inflammatory agents. So now there is only the anti-clotted stents are used. Actually, even absorbable stents, at the time absorbable stents was used. So it also is increasing the heart attack and recurrent repeating. The blocks are very high, so it was taken out from the market. This absorbable, that is now we are using this the stainless steel sort of stents. Actually, it's a foreign body, so it will definitely increase the inflammation. And also the bypass surgery, how much inflammation we are introducing, because you are cutting open. Only you are able to do it only because of the anesthetic techniques. You are able to put the patient in under anesthesia, and the patient is not knowing the pain. Can you imagine without anesthesia, opening your chest wall and doing some, and it's almost 10 or 15 centimeter long incision on both the legs most of the time to harvesting the blood vessel. And also your the chest wall blood vessel is taken out from there, because it's for the surgeon it is no problem, because they are expertized in that. Your chest wall is opened and the internal vein artery is taken and given it to other place on the saphenous veins from the leg is taken, and put, and actually it's a vein we are using for the bypass. So it can be reblocked is very common. The most effective is actually the internal mammary, that is artery itself, and only one part is already attached there. So minimal intervention is done. So that is the best actually for the artery. But you are compromising your own system, your chest wall, your breathing. The breathing, that is the heart muscles, is definitely needed. Also your breathing muscles, you need the respiration also. They are supplied by these blood vessels. See, basically, it's if you are willing. I want to convey is, if you are the inflammation is the basic problem. It's all inflammatory disease. None of this surgical procedures is reducing the inflammation. Actually, it is aggravating the inflammation. Medications are anti-inflammatory. That is one or way or another way. It is reducing inflammation. This clot formation itself is an inflammatory procedure. So it is blood thinners are anti-inflammatory. But we should understand one more thing. When you're taking a medicine, anti-inflammatory medicine, it is actually blocking your healing mechanism also. That is why in the clinically supported lifestyle correction, we try to reduce the taper of the medication at the earliest, but with the evidence, with the test report and the symptomatic relief and the test report, we reduce the medication, because all these anti-inflammatory, almost all the medicines we are using one or other way, it is anti-inflammatory, and anti-inflammatory medicines will, that's a parallel pathway, and inflammation and anti-inflammation of the body is the healing mechanism. The healing mechanism also will be blocked. That is why we try to come out of the medication, not only because of the it's to get the patient, repair the body. Actually, we are in the clinically supported lifestyle correction. What we are trying to do is to repair your blood vessels, repair the heart muscles, and to make the natural anastom, this bypass. Our body has tremendous capacity to repair it and rebuild it. And there is actually 7 years, that is the time of rebuilding. Every day, every minute, the cells are changing, we are changing. So we make use of that and make it possible to repair your body. So you can have new blood vessels to come. And we can see it with the modern medical diagnostic techniques. We can see it so if you want to study the coronary artery itself, you have to go some invasive procedures. But you can check the same thing in the peripheral artery, and we can see the changes in your symptoms itself. The peripheral artery opening up of the leg arteries, and the carotid artery, the plaque thickness of the carotid arteries, we check every 3 months actually for this carotid artery. And also that gives an impression for the doctor also, the evaluation of whether the patient is doing it correctly.
We come to the end of this episode, the second episode, where we were looking at the various possible treatments currently available for improving heart health. And in the next episode, we look at the various comorbidities. That's in the third episode, we look at the various comorbidities that are usually associated with patients who have heart disease. Thank you. The informed patient is key to treatment success.